Good morning and welcome to today's webinar on nurses on the front line in the pandemic 2020 spring, winter and spring, I guess I'd say. And welcome and thank you so much for joining us. Our webinar today has been organized by the Development Office of our Academic Health Sciences Center. And it's in response to the many questions that they have gotten and that many of us have been thinking. So how have our nurses, the profession closest to the patient on a moment-to-moment basis, been responding to the tremendous challenges of this pandemic? Nurses have been in the headlines nationally, and we're wondering what's happening in our own community, in our own neighborhoods. How have our nurses, our administrators, our educators, our direct patient care nurses been able to respond to this, to the threats and the challenges and the uncertainties of this pandemic? So we put together a panel today, and we're going to start by hearing from each one of our panelists. We are also going to have a time when we are open to questions. So please be thinking if we miss something that you really want to know about, get that message to us so that we can answer it. And then I'll do just a little summary towards the end. Again, welcome everyone, including our panelists. And what I'd like to do is start with nurse administrator, Peg Gagne. And Peg has had a variety of nursing positions at our academic medical center over the years. And she right now is the interim chief nurse of the academic medical center. And so I want to say good morning, Peg, welcome.
Good morning.
And would you start off by telling us a little bit about what this experience has been like for you and the kinds of things you're learning by leading through such a unique experience?
Thank you, Pat, for inviting me to be part of the panel this morning. I think, you know, certainly this has been one of the most challenging things or situations that we have ever faced as leaders and as nurses. You know, leaning into uncertainty and challenges is part of our profession, but I think we've all been called upon to a different degree with the challenges that have been presented to us with COVID-19. You know, the organization and nurses have been integral part of rising to the challenge and just leaning into this over the past several months, looking at changing the configuration of our units and the kind of care that we provide. And, you know, looking out, if you think back to the beginning of March, where we were looking at the experiences of other countries and areas within our own country who were experiencing high volumes of patients and shortages of critical materials. We didn't know what our experience was going to be like in the state of Vermont at that point. And so we were preparing for all of it, you know, setting up additional spaces at the Patrick Gym and helping to support what happened out at the expo, and also changing the configuration of our floors and units here at the medical center. So that unknown was big, and I think the picture changed day to day, and we had to adjust our response to that changing picture all along. And just to give you a snapshot of what different areas we're experiencing, you know, in the emergency department, nurses and staff needed to reconfigure the workflows so that as they were caring for potentially COVID patients, they also had safe spaces to care for the other emergency cases, which are an important part of the service that we provide to the community. And you walk through the ED back in January and you walk through the emergency department now and you wouldn't recognize it. You know, they have built a new triage area and an area to care for patients who come in with respiratory symptoms or COVID-19 possible symptoms that is totally separate from the areas where they care for other emergency procedures. And, you know, they built screening areas outside the emergency department so that they could safely screen the patients who needed that, but also could maintain operations. And so I think it's, even just driving by, you can see the amount of change that they were a part of down there. And in addition to just changing the configuration, of course, the practice issues changed as well. The PPE that they needed to wear, the protective gear, and how to do the testing, and, you know, figuring all of that out in a pretty short period of time was just amazing to watch, I would say. It also, of course, impacted our inpatient areas. So our neurosurge unit became our COVID inpatient unit for patients that didn't require critical care. And so we had to move the patient population that's normally on that unit to another area. And there are a couple of expert nurses who moved with that patient population to kind of oversee their care on another unit, but had to, I'll say, get used to providing care in the Miller building, which I think they enjoyed, but also overseeing other nurses who were participating in the care of those neurosurge patients in a different setting, and really helping out with that.
You know, that was the one point you made, Peg, that is so important, that because we are the tertiary care emergency room, it's important for patients to know there is a safe way to come in if you have a problem that's not COVID related, but that you would normally go to an emergency room for. And the way you described the triage center and the different patient flows is, I think, so important. Also extremely difficult to manage and staff and keep everything going smoothly. So I'm glad you mentioned that.
Yeah, I think it, you know, has changed what it looks down there, but it's, you know, there for the safety of our patients, and also to support the new staff workflows that are part of that. So, I mean, I could go on and on about how nurses rose to the challenge. You know, I think our COVID unit, when I go up there and went down to their break room in the time where we were, we eventually got to the point where face shields were absolutely an important part of PPE. When we started this out, we were discarding them after every use, and then realized that we could reuse them. So when you went into their break room at the end of the hall, what you saw was like petals on a wall of all of these little hooks with the face shields and the names, and pretty incredible in terms of the number of folks that were stepping up to provide the needed care.
Yep.
So just so proud of everybody.
Yeah, thank you for that picture.
Mm-hmm.
Let's turn to Deb Hebert, who talk about being in the hot seat. Deb is the manager of our medical intensive care unit, and that, of course, is where our most critically ill COVID patients have been going. So, Deb, could you share with us some of what it's been like to be the nurse manager of the medical intensive care unit?
Absolutely. Good morning, and thank you for having me part of this webinar. I really appreciate the opportunity to talk about this. First of all, I am just so amazed as to what Peg said, the strength and the resilience of our nurses. We have incredible nurses who work here. Uncertainty, we have definitely been in uncertain times, and things changing frequently as the CDC recommendations changed, our PPE changed, our processes changed, and really trying to keep on top of it. When we started out with COVID, we were learning as we were going along. And when new guidelines came out, we would kind of shift gears to make sure that our number one priority was keeping, our patients and our staff safe, making sure that we had what was recommended. Our nurses have been amazing. We have had the opportunity with the COVID patients, because the ones who have been with us have been so critically ill. They have been receiving one-to-one nursing care. They're being taken care of by expert nurses doing a phenomenal job. We have had our nurses, in order to decrease the exposure of our environmental service workers, our nurses are cleaning the rooms on a daily basis for our COVID patients. Our nurses deal with being the medical ICU. Most of the deaths that happen in the hospital happen in our units across the board on a regular basis. So our nurses are used to dealing with death and dying. That, is intensified without the presence of families here. Our nurses have stepped in, and they're the ones staying at the bedside, holding the hand of somebody if their family can't be here with them, and reassuring the patients every step of the way. I think one of the most challenging things has just been supporting our staff and making sure that they feel safe and that they have everything they need. There's not one person who works in this organization that doesn't have somebody at home that they would not want to bring this virus home to. So making sure that they have the tools that they need, the equipment that they need, that our staffing ratios and model is what they need to make sure that they are providing safe care. I think, the outpouring from our colleagues throughout the organization, we have had other units who have not been touched by COVID on a personal note, because they're not taking care of the COVID patients, and that's that sense not being touched. We've all been touched by it, but they have put together gift baskets, they have put together food carts, they have sent meals to our staff. The community outpouring, I've gotten phone calls from real estate agencies, from different organizations saying, what can we do to support your team? So that has just been so inspiring, and that has really kept our staff going, just to know how supported they are.
Deb, I've got two quick questions for you.
Yes.
I just can jump in here, and I'm also kind of watching the time, but I think two things that people are so curious about is, number one, do we know whether any of our direct care nurses actually came down with COVID themselves?
To date, we have not had one of our staff members test positive for COVID. So there has been zero transmission from the medical ICU.
Great. And the other thing I think people might be curious about is, how have nurses at the bedside helped with the families, the communication? There are times when the family couldn't come in. What did they do to try to bridge the gap there?
So we have nurses that talk to families 3, 4, 5, 6 times during their 12-hour shift. They're, they will take a phone in and hold it up so family members can talk. We also recently have had some iPads brought in so we can do FaceTime phone calls with family members. But our nurses really have been at the bedside, filling in for the family, and in constant communication with family. We have, we call them get to know me boards. It's something that one of our nurses came up with a while ago. So our case managers are actually working with families and filling out details about, what did this person, what was their favorite food? What was their favorite activity? Do they have a pet? And also sending in pictures. And so we've been printing off colored pictures of our patients, living life really, and posting those in their rooms. So, we see this patient in their life as the person, as the father, the brother, the wife, the mother that they are. And it just really brings the human element out so we can see them living their life, you know,
Thank you,
and
Deb.
I think that's been really good for families as well.
I bet it has. Yep. Thank you so much, Deb. I'm going to just switch over to another of our panelists, Stuart Whitney. Professor Whitney has worked as a staff nurse on Baird 6 for at least 30 years because I worked there with him, and is coordinating of the undergraduate, the baccalaureate nursing program at UVM. And I would like Stuart to talk to us a little bit about what it's been like as an educator. We have the senior class graduating early so that they can help out with the pandemic. What did it take to make that happen?
Thank you, Pat. Sadly, it's been closer to 40 years, but I don't want to blow your cover either. Anyway, we had 4 days to convert a face-to-face curriculum to an online version because in a very short period over spring break, the faculty was expected to answer the call when the president shut the university down, and the hospital said at this point we would not also like to have students present, and that made perfect sense. And as you can see now, the hospital is making every step possible in order to allow those students back when it's safe to do so. So for the past 7 weeks, our historically, and you know how steep in tradition we are at the university, our face-to-face lecture, patient-centered clinical experience has all become very virtual and very much online. And fortunately, we had a very qualified and IT savvy group of individuals who made the transition almost seem effortless, even though there were a lot of bumps and grumbles the first couple of weeks, both from faculty and students. The thing that we had to keep in mind is that this, particularly for our seniors, this is not at all how they wanted to end their college career. They were immediately, banned, so to speak, from campus and had no time to say goodbye to friends, have the usual farewell get-togethers and celebrations that go along with a college graduation, and has for forever. So this is unprecedented, and they went through a little bit of a grief process. They were angry, they were discouraged, they were disappointed, but true to form, and I'm talking about the faculty as well. True to form, in about 2 or 3 weeks, everyone fell right into line. Everyone was doing their assignments online, paying attention, having great discussion. And what we learned was that the learning can still continue without having to be face-to-face. And we've known that from all the online programs that are across the country. But it's difficult when you're dealing with 20-year-olds or 19, 21-year-olds and trying to teach them the craft and the science of nursing. It's difficult remotely, but we've all managed to get through. We've learned some valuable lessons. We've learned a lot about each other and the resiliency. And as a result, we have at least a senior class that we feel very comfortable graduating. There was no need to delay graduation. Since there is no formal graduation, there will be ceremonies and the like. But we're very happy just to support getting them completed with their undergraduate degree early. Allow them to qualify for sitting for state licensure, and getting to work whenever everybody on both sides of the equation is ready to have them. I think there's a little bit of work on the on the medical or acute care settings, the home care settings, regardless of adapting their orientation policies to reflect what this group of new grads needs. But I have every confidence we can get those into place, and we will orient these new grads into the profession just like we would any other year. We've learned a lot, but there's been certain tragedies across my career in nursing that have taught us a lot as well. And so as we go forward, we're just going to be better prepared. And I hope that the nurses that have been on the front lines getting excellent press, now finally the world knows what nurses have been doing forever. It's kind of cracks you up that, you know, it took a pandemic to get the word out what the value of nurses and frontline caregivers. But I think the experienced nurses will welcome a very fresh and they're not naive anymore, new graduates into the workforce.
Great.
One of the things, and this might be a good segue into my colleague who's here, but one of the things that has been very helpful for us at the university is that we have a public health nurse faculty member who is very knowledgeable in epidemiology and epidemics, and she has created constant up-to-date communication about the virus and its implications to practice.
Well, thank you. That's a very nice lead in to Rosemary Loosekey. Professor Loosekey is with us today also. And as her area of expertise is public health, but she was living a pandemic experience while teaching the senior nursing students about epidemiology and pandemics. And so I'd like to move to Rosemary Loosekey and ask Rosemary if she would explain to us a little bit about how this pandemic has provided her with a teaching example that will be invaluable to the students.
Okay, well, thank you for having me, Pat. First of all, you can imagine that for many students, public health is not really something that's very high on their in their education. Like, oh, we have to do a public health rotation. Why? Having a pandemic kind of answers the why. So it's been really quite an amazing opportunity to kind of capitalize on in order to bring home the importance of public health. I've always told the students the very fact that public health exists is so that the patients don't end up in the hospital. And there are so many things in public health that we do that prevent people from going to the hospital, that everyone pretty much takes it for granted. You know, turning a faucet on and getting clean drinking water. We take these things for granted. So people don't really have a very good consideration of where public health fits into the whole picture of, I want to be a nurse when I get older. So the pandemic was really quite an unprecedented opportunity, should I say, to try and teach them about the work of public health and about the complexities of public health. It's not just about going out and giving, you know, pediatric immunizations. It's not just going out and trying to stop people from smoking. There are many avenues that you can go down if you're going to be a public health nurse or just be involved in preventive medicine generally. So, you know, we had to take the clinical and put it in an online format. So here am I, where I've got students scattered all over the United States trying to think, okay, well, we're not all together and we've got this great pandemic. How can I make this real for them? How can I get them to understand public health? And how can I get this to have value to them? And the thing is, what I found, because I knew these students before they came into the public health clinicals, that there was a huge amount of fear. They were going to be graduating soon. They were going to be going into hospitals where this pandemic was raging and these people were getting really sick and dying. And it was a very fearful thing. So, you know, how do you combat that? Well, knowledge is contrary to fear. So I thought, let me get my students really thinking about this in all directions so that they feel comfortable in their knowledge base about what we're doing to try and mitigate this, what we can do to stop it before it even gets into the hospital. And then how does this really, realistically affect them even when they are in the hospital, donning and doffing and taking care of patients with COVID-19. So I had to get creative. We kept a lot of the similar elements, the same elements in my curriculum that we would normally have done. We did some virtual online field visits. We did a community health assessment, but I also established an emergency operating center, an EOC, Emergency Operations Center. And each of my students had to take a role in the EOC and start researching from their particular perspective what was going on with the pandemic and how they could bring it in so that we could all start thinking, What would the next direction be? What do we need to put out to the public? So I had them thinking on a global level. I would have someone researching what's going on with the WHO, World Health Organization. I'd have them looking at it on a national level, getting the information from the CDC, and then we would take it down to a local level. And of course, for us in Vermont, it would be the Vermont Department of Health. Other students were dealing with their own departments of health in Massachusetts, in New York. And we were bringing all this information in. I would be sending out HANs to them, which are health advisory notifications coming from VDH. And they had to report once a week with all this information, bringing it in. So suddenly they understood where we were on a global level, where we compared nationally, and on a local level, what was our incidence rate? What was the mortality rate, the comorbidities that went along with the patients that were actually dying from COVID-19? So we had a very real and very live experience trying to understand this disease and trying to predict, even though I don't think anyone can really predict, what the future course of it would be. Where will we be in 2 months? And with the ever-changing scenarios, we started where they were recommending don't wear masks. Now they're recommending that we do wear masks. And so with all these changes, we were able to look at it and understand why these things were, these directives were being given, how we needed to adapt and change our behaviors. And of course, their understanding made them much more comfortable with this whole disease process that was going on. And I would like to think that with this knowledge that they're taking with them, not only do they know the resources they can go to get truth, to get the knowledge they need, but they're much more comfortable going into a setting and being able to take care of patients actually in the hospital. I think the majority of them have actually really enjoyed this just because it has been such a live experience for them compared to perhaps just the traditional things that we would normally do. But I've had a lot more interest with people saying to me, I think I might like a career in public health, where do I go? So I think the pandemic, for all the misery that it's brought, has actually been a very productive experience for the nurses to see what's going on. And of course, they're better prepared to see what will happen in the future.
Oh, that's so exciting. I know that we talk a lot about the social determinants of health in almost all of the nursing classes. But again, this pandemic has brought some of those components of learning to the forefront when we talk about, well, where are the communities that are most at risk and why Absolutely. Are they? And what are these global things, as you say, when you turn on the faucet, clean water comes out,
yes.
That really have an impact on our health. So it is such an exciting field at any time, and with or without a pandemic. But that sounds really interesting, Rosemary. Thank you so much.
Thank you.
Now, we may be able to come back to any of our panelists, depending on how we do with time, but I want to make sure we get to Mark Reitman, who is with us this morning and taking time away from direct patient care. He is a nurse at the medical center and has been key to providing care to patients both at the medical center and when the medical center started helping our colleagues in long-term care. So Mark, could you share with us what it's been like for you providing direct patient care?
Yes, thank you for inviting me to participate today. And wanted to start off by, is the volume too low?
A little louder would be great.
Okay, is that any better?
It is better.
All right. Well, I'd like to apologize up front, as public speaking is definitely not one of my strong suits, but very thankful for the opportunity.
Actually, maybe a little louder, Mark.
Sorry, maybe because I'm in a hotel here. I apologize up front because public speaking is not one of my strong suits, definitely, but thankful for the opportunity. A little bit about myself. Probably took an atypical approach to nursing. I started actually as a police officer in the Marine Corps during 9/11, and then have been an RN for 13 years. Oncology experience. I've been an auditor in public health sector. I was one of the administrators for the Medical Reserve Corps program in Georgia. That's where they respond to natural and man-made disasters. And then I joined the team in Vermont last January, and now am part of Baird 3. That's one of the inpatient medicine telemetry units. That was one of my experiences here. And then the second would be at Birchwood Terrace, which is a skilled nursing facility and physical rehabilitation center.
Great. So on Baird 3, were there? It was not a designated COVID unit, but were patients moved to Baird 3 so that McClure 6 could be freed up?
Yes, it was just part of the university's plan. After McClure 6 filled to a certain percentage capacity, then Baird 3 was.
Oops, we lost you, Mark. We can't hear you, Mark.
I'm sorry.
How's that? Yeah, better.
Baird 3 was part of the plan after McClure 6. I believe filled to 75% capacity in the next UI unit. And then that's person under investigation. So while the patients were awaiting their test results to see if they were negative or positive, and then they would transition to either a COVID positive unit like McClure 6 or McClure 4, or
Okay.
to one of the medicine
So you
units.
said you used that term, which I've seen in the literature, and I hear people respond to PUI, person under investigation. Is it?
Correct.
Okay. So when you're caring for those patients, you treat them as though they have COVID-19?
Yes, ma'am. So that definitely changed the way that the daily activity and business processes were done on the unit. I'd like to thank the leadership team. Can you hear me?
Yeah, just barely.
Sorry, this isn't going very well on the side.
You're doing very well. It's just the volume.
Thank the leadership team.
You're doing great.
Oh, I'm sorry.
Yeah.
I'd like to thank the leadership team for their tireless efforts to plan, prepare, train, and communicate, like the ever-evolving plans and processes through this. Some of those process changes, how care was delivered, was you had to be thoughtful to how you maximized and clustered patient care, because you wanted to minimize the contact or exposure for the staff and possibly other patients too. So even down to the medication level, we would store patient-specific medications in a lockbox in their room. You could do medication or have just one nurse or basically a runner outside. So if you forgot something, you wouldn't have to come out of the room, doff all your PPE, and then get that item and return back to the patient bedside.
Yep. Well, that's a great example of changing the processes. So normally we go in and out of patients' rooms, get what we need, come back. But when they're on isolation like that, having someone bring what you need to the room makes a lot of sense, and it would save on equipment, right, Mark?
Oh, without a doubt. So PPE was a primary concern, and just for the staff, the anxiety and fear of possible transmission to them or their families is a real concern too. So being conservative with PPEs and aware of that, and limiting exposures were probably the primary concerns. But even the consideration had to be given to the social distancing aspect. So previously you would meet in a group and have a report, or you would do bedside report too for patients, and strategically you would space out the staff and conduct that in more distantly.
I can imagine.
Like the clothes you wear and everything.
Right. I mean, at the nurses' station, that's where you often meet and talk things over and plan, right?
Correct.
So you have to keep that
use of technology too.
Yeah.
Like you can use iPads as we're doing today, Zoom. You know.
Yeah. So let me just focus for a minute on the collaboration that we started with the skilled nursing facility at Birchwood when, and I've heard Peg describe this, we got a call, she got a call asking for help with staffing because so many of their patients were ill and so many of their patients were critically ill. So Mark, could you just tell us what was your relationship to the team that went over to Birchwood and what did you do there?
Definitely. I have some background information there. I wasn't there at the very beginning because Baird 3 was still a person under investigation unit there, a COVID unit. So shortly after there, I guess the good side of it was there wasn't enough patients for us to continue to have a full unit operating there. They were able to shift back to McClure 6 and MICU. So that was definitely a positive, but it gave me the opportunity to join the palliative care team, the collaborative team that also involved staff members from UVM's network, the home health and hospice unit, their chaplain, their nurses, some of their providers. And then I basically was able to join 2 weeks after they had started. The reason that they had was, as to what you said, a lot of the patients had started testing positive, and then staff also. So there were staffing shortages as staff members had to be quarantined or develop symptoms. And then UVM was able to come in and basically, as I had heard from one of the staff members, bring the hospital to Birchwood. So Birchwood isn't really set up logistically like the hospital. You don't have isolation rooms, you don't have negative pressure rooms, there's safeguards and just how the facility is structured. So through the generosity of the university and donors and community, he was basically able to set up those facilities outside of Birchwood grounds. So in the back, there's different facilities that were created and an RV for the palliative care staff so they could limit their time within the building and be able to safely don and doff and take breaks. And provide that 24/7 care to the patients.
Okay, and so did you volunteer to be on that team, Mark?
I did. I didn't hear about it until about a week and a half after they had developed and volunteered. I think it was just part of my natural experience, primarily through the public health service, like the Medical Reserve Corps, and I just wanted to be there with the patients and the palliative care. Some of my oncology experience, it just touches your heart to be part of the community.
Yeah, and how did your oncology background help you with that experience, Mark?
I would say more towards the end of life type of care, because I know there's mixed news to how the coronavirus affects patients, but from being there at Birchwood, you can see the rapid onset of how that affects patients, and especially those with comorbidities. Oncology, you see more of the end of life care. Palliative, though that doesn't encompass all of what palliative does, it's a large portion, the end of life care. So you have to discuss with patients and families like their goals of care.
Right.
Since many of the patients consider that their home, like if they're approaching an end of life decision, they want to remain in their home. So that was a large decision there.
Right. And as much as possible cared for by people who know them. So with staff at Birchwood testing positive and having to stay away from work for 2 weeks, the staffing was quite a tremendous challenge. So that teamwork sounds great. And I believe that are you still scheduled there, Mark? Is that where you're doing clinical work?
We are. We basically have a team where we can set, like a typical schedule around the clock right now. We're in the phase now to where it's kind of transitioning out and doing that education portion with the staff there and making a safe exit strategy. I was trying to think of the word there, but basically we want to make sure the staff there is comfortable and they're in a good place. Still
Right.
patients that are symptomatic there, but it's just part of the evolution. They've created an excellent model so it could be replicated throughout the state, and
Yep.
definitely valuable.
Yep.
Several stories there you can tell that are kind of heartbreak and resilience and recovery too. But
Yeah. And how did you? Let me just ask
how
how you interacted with family, or how you are interacting with family, because that's been such a cause of concern when we know families who can't go in to visit. How are you as the nurse helping the families?
So I would say that's similar to the inpatient model. You can definitely do your phone calls. Most of the time, if we had the capability, you wanted to use like the iPad technology, the Zoom technology, because there's the aspect of being able to see each other on the screen. It's not the same as being there in person, but the next best thing, I guess. They actually allowed last week some of the family that were local to come in and be with the patients at the end of life if they chose to, and it was a safe plan to do so.
Did they put on personal protective equipment?
Correct.
The families.
They
Yeah.
The families.
Okay. Well, thank you so much, Mark. You did great. And
Thank you.
yeah, and I'd like to see if any of our panelists have something else that they wanted to add that they didn't quite get in there before I switched us to someone else. Is there anyone who had something they really wanted to share? I'll let you think about that for a minute, and then I'm wondering, if questions came in, how would we know that? I need to ask some of our organizers here. Anyway, you can let me know about that. I'm going to go back to one topic and ask first Deb Hebert to answer this. So you did mention fears and concerns of the staff. How have we been trying to help with the individual fears and concerns of the nurses who are providing direct patient care?
I'm not sure. Okay. I was just waiting to see if I was unmuted. Education, I think, and communication. I have had a few nurses that, I have reached out to our infection prevention colleagues. I know Carolyn Trehune, Kemper Alstead have made personal phone calls, as has Cindy Noyes, to staff members who had questions about their own personal safety, and have been able to answer the questions. So I think, when questions have come up, we've really reached out to get the education and information for our staff on how they can keep themselves and their families safe. The organization, as you know, had made arrangements so if people didn't feel safe going at home or going back home after working, they could get a hotel room free of charge. We have had a few of our nurses who have taken advantage of that, either had small kids at home or their families were fearful of them bringing something home. They've opted to stay in a local hotel for their stretches of time that they're at work. And we have had a couple of our nurses who are expecting babies that we had worked with at the very beginning of this pandemic, and they voluntarily got reassigned to help out in other areas that had nursing needs. So, you know, a variety of different things that we've done, but really communicating and talking with people has been necessary every step of the way.
Thank you, Deb. We do have two questions, and they're both for you, Mark. Let me just read the first question to you, Mark. This person by the name of Annie has written in and said, does Mark have a specific moment with a patient, either at Birchwood or at UVMMC Baird 3, that was particularly meaningful and rewarding to him?
I would say several moments, but there's one that definitely stands out at Birchwood, without giving away someone's name, but there was a patient that had just tested positive for the coronavirus, and then he was in his room and had on the television and to a news station that's talking about COVID-19, and then his roommate had been positive also and was actively dying. So he described the moment as kind of mental anguish, as his roommate was just repeating a family or a loved member, a loved person's name over and over, and he related to that, to how he might end up also, but through resilience and just recovery, it turned out to be one of those recovery stories to where his wife actually was in the memory care unit and was able to reunite with her, and that's where they're both at right now. So it turned out to be a lovely ending for that group of people.
Yep. So that's lovely. So that patient was able to communicate to you his anguish and the thought of how he might be in his final moments as well. So he
definitely,
sounds
and
like
the services that were being
trusting relationship with you. Well, Mark, the next question is for you too. And this person is just wondering if you have come here as a traveling nurse under contract. And if that is the case, how can we get you to stay permanently? That's
well, first, let me say thank you. That's very kind. No, actually, I am part of the permanent staff. My wife had, long story short, but my wife is also military and has served the veteran population, and she's part of the Veteran Affairs medical group as a physical therapist. So she was offered a job for the local clinic here in South Burlington off of Lakeside, and we came up almost 2 years ago and looked at the area and both fell in love with it and decided to make that move, and we love it here. I'm glad to be part of the team.
Great, that's just what we wanted to hear. Thank you so much, Mark.
Thank you.
Let me just say that we have a question for Stuart Whitney. Stuart, what plans are in place to integrate more pandemic or crisis management into the nursing curriculum? And how is self-care? So this is really two questions. How is self-care? In other words, how do you care for yourself through crisis and pandemic? Is that in the curriculum?
Well, it is now. I have a question for Mark first, and he doesn't need to answer. I can give him lots of practice in public speaking if he would like to come across the street and do work in the Department of Nursing, because we would welcome him on our faculty as well as being welcomed as staff. We are we just like everyone. When they say it feels very trite sometimes when you say we're all in this together, but we're learning as we go as well. Not necessarily how to do what we're doing right now, but what does the future look like? We're preparing for an academic environment that none of us have ever seen before. And we're just not going to open up, and things are not going to go back to normal as much as we wish and hope they would. But we've got, incoming freshmen, we've got students returning in the fall. So we are shaping up to just perhaps reorganize our curriculum to focus much more on public health and get us through this pandemic. And take advantage of not just Rosemary Loosekey, but take advantage of this once in a lifetime educational situation. And so our curriculum will be reflected by the new rules, the new policies, the new procedures that are dictated sadly by this epidemic, not by CARE. The epidemic is in control so far, but we'll be listening to our practice partners to figure out what skills do our students need in order to work just as effectively as historically in the new environment.
Thank you, Stuart. Thanks. That's great. We've got, I don't know if we can get to 2 more questions, but we certainly can get to this next one. And this is for anyone to answer. What are the plans for the future for the staff? Are we going to do some sort of special post-crisis support and care for our nursing staff?
Well, I can speak to some of that. I would say we have had an active group of employees that have worked together to build wellness strategies and support our staff right along during the pandemic, and that will continue. I think they delivered wellness bags to all of the different units. They have set up areas on the units for people to rest and take their masks off and be supported in that way. So I think that's been part of the plan all along, and we know that self-care piece needs to continue. Thanks.
Great. We are getting short of time. I would also say quickly for you, Peg, do you see long-term nursing staffing procedural changes?
I would say absolutely. I think there's a group right now of our staff nurse 4s, which are our clinical experts, that are pulling together the clinical guidelines that go along with caring for patients with COVID in all settings. So pediatrics, labor and delivery, what does it look like on each of the different areas, and that will be sort of the base that we work from to decide how practice changes are going forward.
Great, thank you, Peg. And we have not a question, but a statement coming from the provost at UVM with a big thank you for faculty, for staff, for everyone involved with this pandemic and the responses that we have had to come up with very quickly. That was from Patty Prelock. And I'm just looking at the time. I think I will just make a couple of sort of ending or summarizing comments. And as I thought, this hour went by very quickly, and I can't thank the panel enough for being available and for having some thoughts prepared, and also for answering spontaneous questions. I know that there are many, many more stories, and that we could and would like to listen to more. And I hope we will find a way for people to keep sharing. I think with that emphasis on process and what happens next, and part of that is how do we share? How do we keep talking about and sharing the experiences that nurses have had? I think it's going to be very, very important. Many of us, most of us, maybe I would say all of us on the call today, I have been wondering, so how do we help? How do we help those who are directly providing care, those whose jobs have been affected? And how do we keep our teams strong at the medical center and at the university, producing fine nurses and supporting our fine nurses? And the development department does have some ideas about that, and they will be in contact with you. One that I'd like to suggest that we can all do is uvmhealth.org has a gratitude page where anyone can sign on and leave a message of gratitude for the staff and the managers and the wonderful teams working day in and day out, both in all phases of this pandemic. And I think most of us are aware there are tremendous interdisciplinary care going on, and care throughout the UVM Health Network, both at the Academic Medical Center, the community hospitals, with our home health agency, and our hospice and palliative care. And all of that has been impacted and has been absolutely important for our response as a community. I am so glad, as Stuart said, you know, here's a chance to highlight what nurses do and their contributions. I would like to end with a quote from Maya Angelou, and just to leave you with this thought. And she said, as a nurse, we have the opportunity to heal the heart, the mind, the soul, and the body of our patients, their families, and of ourselves. The patients may not remember your name, but they will never forget how you made them feel in their time of need. So with that sentiment, I'd just like to thank everyone again. Thank you for your support. Thank you for your support of nursing care.
Thank you, Pat.